Thank you all for joining me today for our webinar, Telepsychiatry, Talking to Your Clinician in the Digital Age. I'm Dr. Shabana Khan. I'm a child psychiatrist at the NYU Child Study Center. And you can submit questions at any time today by typing them into your questions pane of the control panel that's on the right side of your screen, and I'll answer questions at the end of the presentation. I'll start with basic definitions. So what is telemedicine? What is telepsychiatry? Why do we need these services? Major applications of telepsychiatry. I'll provide an overview of the Telepsychiatry Program here in the Department of Child and Adolescent Psychiatry, and then I'll take questions at the end. The American Telemedicine Association defines telemedicine as the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. Telemedicine includes a growing variety of applications and services using two-way video, email, smartphones, wireless tools, and other forms of telecommunications technology. Telemedicine is closely allied with the term health information technology, which typically refers to the electronic medical record and other information systems, while telemedicine typically refers to providing clinical care remotely using technology, two-way video. And telemedicine is a process of providing healthcare from a distance through technology, often using video conferencing. Telepsychiatry is a subset of telemedicine that uses real-time interactive video conferencing to deliver psychiatric care and other mental health services that are usually provided in person. You may also sometimes see the distinction between telepsychiatry and telemental health. So telemental health, including all applications, mental health applications of telemedicine, and telepsychiatry specifically referring to psychiatric applications. Telepsychiatry is similar to in-person visits, except that the doctor and the patient are in different locations, and both locations are going to have either a computer monitor or a television screen that allows two-way communication in real time. Research shows that telepsychiatry is just as effective as the treatment that's provided in person. Much of the research that we currently have in telepsychiatry is in adult telepsychiatry, and research with children and adolescents is just beginning, and it shows that children, families, and referring practitioners are very satisfied with the care they receive through telepsychiatry. So why do we need these services? There's a national shortage of psychiatrists, particularly child and adolescent psychiatrists, and especially in rural areas. So our department uses telepsychiatry to extend our reach and fill those gaps in care. About 60% of psychiatrists are age 55 or older, so there's also an aging cohort effect where a significant portion of our workforce will be retiring in the next 5 or 10 years. So we do need to come up with innovative ways to extend our reach and address this shortage. Rural areas often have difficulty not just recruiting, but retaining mental health professionals. So often clinics in rural areas may have a significant amount of turnover of mental health professionals. So telepsychiatry being implemented into these settings can provide that long-term continuity of care. Mental health services can be very limited and even non-existent in underserved areas. So telepsychiatry can improve access to specialty care that might not otherwise be available. Often pediatricians and other primary care providers are faced with providing mental health care without that specialty training. Individuals, patients, children, families living in rural areas or otherwise underserved areas often spend a significant amount of time and money traveling for care. So traveling from their community to an urban setting to meet with their doctor, that can mean a lot of time off from work, having to arrange daycare, time off from school. So often families may choose to forego this care altogether. So this technology allows us to bring care to the patient's location and also reduces delays in care. So for many of the conditions that we treat, such as autism spectrum disorder, it really makes a difference if you can diagnose early, and that can impact outcomes so that you can provide services earlier on. There are studies that show the diagnosis of autism spectrum disorder can often be delayed by years in rural settings versus urban settings. So using this modality allows us to provide an assessment, screening, diagnosis, and implement treatment sooner. Telepsychiatry can reduce the barrier of stigma. So if we can implement telepsychiatry into a pediatrician's office, more individuals may seek this care. Or if you are meeting with a telepsychiatrist who's, let's say, 100 or 200 miles away from you, it's very unlikely that you'll run into that psychiatrist in your community. So that can also make it more likely for individuals to seek this care. Telepsychiatry can also improve continuity of care and follow-up. So I discussed our workforce shortage. This is a map of the number of child and adolescent psychiatrists in New York State, county by county. So here on the bottom right in New York County, where we are, we have 314 child psychiatrists, which is better than most of the state. And even within our county, there can be access issues and shortages. I'll show you a couple of maps later in the presentation of where we're providing telepsychiatry services, and many of the counties don't have a single child psychiatrist. And as you can see on the map, there are several counties that only have one or two child psychiatrists that are covering a pretty large area, and some have none. And there are some counties that have relatively more child psychiatrists compared to neighboring counties, like 29, 38, 24. And those are counties that have academic medical centers close by with psychiatry departments and child psychiatry fellowships. Telepsychiatry can be used for many things. So the scope of services include diagnostic evaluations. We can use telepsychiatry in forensic modalities. So correctional facilities often have a very difficult time, not just recruiting, but retaining mental health professionals. Prisons can be in very remote areas, and the cost of transporting inmates can be very high and not without risk. So telepsychiatry is often used in correctional settings. We can use telepsych in pre-hospitalization assessment and post-hospital follow-up, case management, various types of psychotherapy. Telepsychiatry is often used in emergency settings. So many emergency rooms may not have a child and adolescent psychiatrist on site at all, or maybe not during evenings and weekends. So implementing telepsychiatry can potentially reduce wait times, decrease unnecessary admissions. So there is a lot of potential benefit there. Telepsychiatry is also used for scheduled and urgent outpatient visits, medication management, which is a lot of what we do with our current telepsych program. So often clinics may have therapists on site who can do therapy, but they may not have psychiatrists for medication management. And then consultation as well. So we can serve as consultants to pediatricians, to adult psychiatrists, other child psychiatrists, psychologists, and telepsychiatry is also used in research settings, can be used for staff training. So if we can provide training to PCPs, other healthcare providers in rural areas, they may feel less isolated and they may be more likely to continue services in their community. We can offer continuing education credits, and also we're seeing more and more telepsychiatry being used in disaster planning. So telepsych can be very helpful in the context of natural disasters to provide care not just to residents in that community, but also to frontline workers. So I want to talk a little bit about the history of telepsychiatry. The first telepsychiatry program was through Nebraska Psychiatric Institute in Omaha in 1959, and Nebraska Psychiatric Institute had initially used two-way closed-circuit television, and they initially connected with the anatomy department that was one block away, and they had a neurologist do a full neurologic exam on a patient to teach students. And once they found that this modality was effective for education, they then asked one of their psychiatrists to provide group therapy using this modality, which they found also to be effective. Then they used it for other things like long-term therapy, consultation liaison, and education. And they connected with Norfolk State Hospital using that closed-circuit microwave television, which was about 112 miles away. And they used other technology like telecopiers to transmit and receive printed matter, such as patient charts, reports, class materials. And I also put in a picture here on the right, the cover of Radio News magazine. This was back in 1924, where radio was first being used as a broadcast medium. And there were innovative thinkers even back then that described something called a radio doctor, so a physician using this radio technology to be able to assess and diagnose patients. Shortly after the program at Nebraska Psychiatric Institute, there were a couple of other programs around that time. So Massachusetts General Hospital in 1967 used this technology to connect with a clinic that they developed at Logan International Airport. So Mass General was located 2.7 miles away from the airport. They wanted to be able to use this modality to provide assessments if there were any air emergencies to any passengers that may come through, and also provide care to employees at the airport. So the image in the middle, that's Dr. Kenneth Bird, and he was one of the pioneers who developed this clinic. And then next to him, those are nurses that were at Logan Medical Station. It was gate 23, and they connected using television to physicians at in the emergency department at Mass General. And Michael Crichton, the writer, he was a third-year medical student at Harvard and he rotated through this clinic at that time, and he actually described this clinic in one of his books. He described it as the clinic where the physician's stethoscope is 3 miles long. So I'll talk a little bit about our telepsychiatry program. We use high-speed encrypted, a secure network to connect children, adolescents, and families with our expert clinicians. Since 2010, our department has partnered with the New York State Office of Mental Health, OMH, to provide telepsychiatry services to inpatient and outpatient Office of Mental Health facilities across the state. Our services include comprehensive assessment and diagnosis for a variety of mental health conditions, medication management, behavioral therapies, prevention and patient education, and we also provide specialized consultation to healthcare providers. In 2016, our program, we started a resident pediatric telepsychiatry clinic. So we have 20 child and adolescent psychiatry fellows, and currently 5 of our 10 second-year fellows are rotating through this telepsychiatry clinic. It's a school-based mental health clinic, and they provide initial psychiatric evaluations and ongoing medication management. It's a year-long clinic through the Office of Mental Health, Rockland Children's Psychiatric Center. And as you can see on the map, we are in schools in Saugerties, New York, Port Ewan, and Liberty, New York. And each of these sites is about 2 hours away from us. All of our work is done remotely through video conferencing. The image on the left, this was one of our former fellows last year who did telepsych. As you can see, in front of her is the video conferencing unit where you can see what the patient site looks like. And next to that is a desktop where she can access the electronic medical record. And then the image next to that, the person waving, that's one of the social workers at one of our school sites in this clinic in Saugerties, New York. And generally, when children come in for an appointment, They're seen, like I said, through video, and the social worker will be on site in the room with the child, and then there's typically the caregiver, the guardian parent also in the room. So in addition to our 5 fellows, we also have 3 attendings that are providing telepsychiatry services. We provide consultation to an inpatient unit in Elmira, New York, which is about 4 hours away from here. And we also provide telepsychiatry services to 3 day treatment programs that are located in schools. And those are in Ontario County, Yates County, and Chemung County. And each of those sites is about 4.5 or even 5 hours away from us. The benefit of providing telepsychiatry services into schools is that we can meet kids where they are. So it may be easier for children and adolescents, less time off from work for patients, less time missed in school, and it's easier for us to collaborate with the rest of the team. So if we have a social worker on site, a therapist on site, we can collaborate with them. The school psychologist can easily be brought in as needed to the visit. The school nurse, we can get a wealth of information if we can, and the teacher as well. So in addition to what I mentioned, at NYU Langone Hospital, Brooklyn, formerly Lutheran Family Health Centers, which is one of the largest federally qualified health centers in the nation, we are going to be offering, hopefully within the next month, school-based mental health services. So there are 18 schools that have, through this program, that have behavioral health social workers on site, but they don't have a child psychiatrist on site. So if the behavioral health social worker assesses a child and they need an assessment by a child psychiatrist, they would have to travel to the Sunset Terrace office to meet with the child psychiatrist. So that can be a significant distance, and that can be a major barrier for some families. So we have 4 child psychiatrists at NYU Langone, Brooklyn, who are going to start telepsychiatry services to 2 schools, PS 24 and Sunset Park High School, with the plan to expand to other schools in the future. Another initiative that we are working on is telepsychiatry into emergency departments. So Bellevue Hospital's Children's Comprehensive Psychiatric Emergency Program, the CPEP, which is the emergency room at Bellevue, has the child psych emergency room, has child psychiatrists available 24/7, which is a very unique program, not just here in New York, but nationally. And I'm working closely with the director of the CPEP, Dr. Ruth Gerson, on implementing telepsychiatry with the Bellevue CPEP serving as the telepsychiatry hub to provide consultation to other EDs in New York City. These are some resources that can be helpful. So the American Academy of Child and Adolescent Psychiatry has a Facts for Families guide, and part of that is telepsychiatry and your child. The American Telemedicine Association website also has a wealth of information on telemedicine, telepsychiatry, and then the American Psychiatric Association has a telepsychiatry toolkit. So now I will take questions. So there's a question on legal liabilities involved. What are the legal liabilities involved that would not be present for face-to-face or telephone consultation, and how to mitigate? So if there are any specific legal questions that you have, you definitely want to consult with your lawyer, your legal team, risk management. I can talk about some of the things in general that we would think about for telepsychiatry. So one of the things that you want to consider is malpractice. You want to make sure that your malpractice provider covers telepsychiatry similar to in-person. So some standard malpractice insurances may cover it, some may not, or you may have to get additional insurance, or they may want you to list specifically what kind of services you're going to be providing. So malpractice is certainly one thing that we would want to think about. And then there's licensing. So generally, and there can be some exceptions to this, but generally you have to be licensed in the state where the patient is located at the time of the telemedicine encounter. So not necessarily where the patient resides, but where they are located when you are conducting a telemedicine visit. And in some cases, you may need to be licensed not just in the state where the patient is, but also where you're physically located. So you definitely want to know your state laws. Some exceptions to the licensing would be a practitioner who's working through the VA, so the U.S. Department of Veterans Affairs, or Indian Health Services. You may not need to be licensed in every state if you're treating a patient through the VA system. Some states may have consultation exceptions. So if you're not taking on direct care, you're merely serving as a consultant, you may not need to be licensed in that state. Some states may have a limited telemedicine license. Not all states have this, so it's good to kind of know the laws. So licensing would be one thing to consider. And then informed consent. So 29 states have some sort of requirement for informed consent for telemedicine. And it could be either a written informed consent, which has to be signed by the patient, it could, or a verbal acknowledgement, which would be documented in the chart. So you definitely want to know the laws there as well for informed consent. Here in New York State, the Office of Mental Health has telepsychiatry guidelines, and we have a required informed consent. And the staff on the patient end will help complete that with the patients and families. And then the other thing that we want to think about in terms of kind of legal liabilities, so the technology that we're using to provide the care, you want to make sure that it's private, that it's secure, that it's adherent with HIPAA standards, the Health Insurance Portability and Accountability Act. So those are some of the things that we would consider. Make sure that you have point-to-point encryption. Some of the other things, I won't go into details, but some of the other things we think about are business associate agreements, audit controls. So those are some of the factors that we would consider. So there is a question about insurance. So insurance coverage. Are these services covered by insurance? So when we think about insurance coverage for telemedicine, I like to break it up. So there's Medicare, Medicaid, there's commercial insurances, and then self-pay. Medicare is on the federal level, and there are certain restrictions on only certain types of providers will be covered, only certain types of settings. Generally would have to be in a health professional shortage area. So there are certain restrictions you want to be aware of. With Medicaid, every state has their own Medicaid policy and their own policy on what's going to be covered in terms of telemedicine. So you want to definitely know about your state-specific Medicaid coverage. And then there's commercial insurance. So again, they're all different. Some states have parity and some states do not. So about 34 states in DC have some form of telemedicine parity, which basically means that telemedicine will be covered equal, or it would be covered just like in-person services would. So you definitely want to know that. And that could be for commercial insurances, or it could be for Medicaid and or Medicaid. And generally, we use the same codes, the same CPT codes for telemedicine. You would just have to add a modifier, like a GT modifier, saying that the visit was done through audio video. So there was a question about what to do if a student expresses suicidal ideation or intent during a telepsych visit. So with this question, I like to think about the type of setting that we're in. So there's clinically supervised settings, and then there's clinically unsupervised settings. So clinically supervised settings, for example, would be if the patient is located in a hospital, in a clinic during the encounter. And then there's clinically unsupervised settings, for example, if you're seeing a patient in their home. So for our telepsych services that I discussed today, we are seeing patients in supervised settings. So the children and adolescents are in a setting where the social worker and or the nurse or there can be a telepsychiatry clinician who's in the room with the patient. So if during that type of visit, a patient expresses that they're having kind of suicidal thoughts and they have a plan, so the telepsych clinician is hearing the same thing that we're hearing, so they can kind of help in that situation. They are definitely going to be able to help. It's always good for us to know beforehand what resources are available locally, so crisis services, and then always having a way to reach clinicians in real time if needed. So if there isn't a clinician in the room or they're right outside, but right outside the door, but they're within the clinic, then you want to be able to have a phone number to reach them directly, or whether it's instant messaging in the electronic medical record, just a way to get them as soon as possible. And then it's always helpful, especially in clinically unsupervised settings, to have the number for the local police department, the fire department, and that can actually change periodically. So you want to make sure you have those numbers updated so that you can get the crisis services as well, so that you can have those resources available to you. Because if you're located far away from the patient and you dial 911, then you're going to activate your local police, not where the patient is. There's a question about how you would best prepare a child and families for a telepsych visit. So if you're in a setting where there's a clinician on the other end, then they can be very helpful to kind of talk through what a visit with a telepsychiatrist will look like, what a typical visit will look like. And then at the initial visit, we want to make sure to introduce ourselves, our credentials, where we're located, and just kind of be very clear on who's in the room. So with telepsychiatry, one of the limitations is that we have that limited field of view. So if there is someone that's in the room that isn't that you can't see on screen, you want to make sure that you're very clear about who else is in the room, that it's a private, secure room, and then have the folks on the other end do the same thing. So that can be helpful. And also there are things that can make it easier for us to be able to provide telepsychiatry to children and adolescents. So children and adolescents may have a hard time, understandably, sitting kind of still and remaining on screen. So certain technology can be helpful for that. So pan, tilt, zoom cameras, where we can kind of get a nice scan of the room on the other end, or we can follow a child around. So if they're kind of under a chair, you should be able to, with that technology, kind of follow them, and that can be helpful. So that's something else that can be helpful, specifically when treating children and adolescents. So I will end there, and on behalf of the Child Study Center, thank you for joining me today. Once you leave the webinar, you'll receive a survey, and we would appreciate it if you can complete it. You'll also receive a follow-up email within a day or two with a link to a recording of today's presentation. We hope that you can join us for our next webinar, 4 Effective Parenting Interventions to Support a Child with Eating Disorder Behavior, with Dr. Michelle Miller, and that's on February 13th at 1 p.m. Thanks again.